Okay, good morning, and thank you, Dr. Krasnow, and thank you, Dr. Agarwal, and the organizing committee for the kind invitation to speak this morning. I have no disclosures. I am a full-time 8/8 surgical oncologist at the Seattle VA. The institutional data that I will show has been approved by our IRB and R&D committees for presentation this morning. The goals of my talk are threefold. The first is to discuss in a whirlwind tour the surgical management of transhiatal esophagectomy. Secondly, to discuss the complications or challenges of combined modality therapy. And then lastly, how to manage the frustrating R1 microscopic positive margin. So to begin, we'll head straight into transhiatal esophagectomy, which is the standard, the most common approach worldwide to manage esophageal cancer, or at least in the US. It's not a new procedure, and in fact, the first successful transhiatal esophagectomy, meaning not accessing the chest, was performed in 1933 by a British surgeon, Dr. Turner, who divided into two stages, and the second stage was actually creating a skin tube connecting the cervical stump at the neck over in the subcutaneous space over the chest, reconnected the stomach where patients would manually propel the swallowed contents back into their abdomen. Needless to say, this was not a common procedure until 1976 when Dr. Oringer at the University of Michigan really pioneered the modern esophagectomy with the cervical anastomosis. And in 2007, with 3 decades of experience, he actually presented his personal series of over 2,000 esophagectomies. The procedure begins right here with incisions in the neck to access the cervical esophagus and in the abdomen. When distant disease is ruled out, the abdomen is opened, the stomach is mobilized, the esophagus is isolated at the diaphragmatic hiatus and is encircled here by this celastic tube. And there it is. And the diaphragm is opened and the entire distal esophagus is mobilized posterior to the heart. During this entire process, it's critical to identify and preserve the right gastroepiploic artery because that is actually the sole remaining blood supply to this gastric conduit, which will serve as the esophageal replacement. Attention is then directed into the neck. The esophagus is isolated. Upper mediastinal dissection is performed bluntly by finger dissection. And here you see the diaphragm opened with the esophagus extending into the upper chest, which is then mobilized. And with complete mobilization of the esophagus, it's divided into the neck, delivered through the abdomen, and a serial fires of this linear stapler divides the tumor by approximately 5 to 6 centimeters away from any gross palpable tumor, and simultaneously creating this gastric tube, which is then delivered back through the mediastinum into the neck, and it is opposed to the cervical remaining esophagus. A stapler is fired to create anastomosis and then closed. With refinements in technique and mostly really advances in critical care, we've dropped the mortality of this procedure to less than 5%. Our institutional mortality is less than 3%. Leak rates have been reported earlier as high as 30%. However, most modern series at high volume centers typically describe rates at 9% at the University of Michigan or 20%. Our institutional leak rate is less than 18%. It should be worth noting that anastomotic leaks are a considerable cause of postoperative deaths. Now, why is that, and why is this anastomosis more difficult than in other areas of the body? There's several anatomic features. One is there's a lack of serosa and a longitudinal muscle or the absence of circular muscles, which both contribute to having the weakest suture retention strength in the GI tract. And it takes longer to heal, typically achieving maximal burst strength 2 weeks post-op. And compounded with the fact is the limited exposure in the small confines of the neck to create this anastomosis. This is a good, actually an excellent study that was published in JAMA Surgery. This was a study, many of you recognize or have heard of the National Surgical Quality Improvement Program, the NSQIP, that was instituted by the Boston VA and spread nationally, and it was an excellent tool to really define surgical quality measures. The American College of Surgeons has actually adopted this with the success at the VA, and over 164 centers were used and defined these predictors of 30-day mortality or death or serious complications. And these include decline in functional status, and albumin less than 3, greater than 10% weight loss in 6 months of surgery, smoking, diabetes, hypotension, arrhythmia, history of stroke, MI, or hypoxia. Now, anastomotic leaks present in various forms. In the early post-op period, they can present in fulminant shock. This typically signals complete death of the gastric conduit or gross technical error with complete disruption of the anastomosis. Fortunately, this is uncommon, and more typically, there are leaks result in confined infections either in the chest or in the neck, depending on the location of the anastomosis. How do we manage it? Well, the patients that present in fulminant shock require immediate re-exploration, takedown of the anastomosis, removal of gastric conduit, creating a cervical spit fistula, and a feeding tube. Needless to say, this is a oftentimes fatal consequence. If patients are fortunate to survive this, they are candidates for potentially second stage conduits with a colon or jejunal interposition graft. Fortunately, the more common presentations, either in the chest or in the neck, are managed by contrast studies, wide drainage, primary repair, covering of vascularized tissue flaps, or just packing the neck wound and allowing it to granulate in. The reason the majority of esophageal surgeons prefer the neck anastomosis is that the infection is at least confined superficially in the neck, as opposed to in the chest and dealing with mediastinitis with a higher mortality. Now, the consequence of healed anastomotic leaks result in strictures and repeated dilations. But over a long period of time, when they heal, they can actually develop esophageal pouches which contribute to recurrent dysphagia. This top one here is a first patient where you see this small pouch of the swallow, and this patient presented with increasing dysphagia. Endoscopic view saw the anastomosis, but unfortunately 2 blind pouches of which food were impacted. We re-explored this patient's neck, inverted the pouches with suture plication. You can show resolution of the pouch endoscopically as well as by repeat swallow. Now, larger anastomotic leaks can result in larger pouches, and in this case, this is a pouch that we simply just resected to show resolution of the pouch as well as complete resolution of his symptoms. Unfortunately, this patient had a transthoracic anastomosis, and that resultant pouch was deep in the chest and would require a complex thoracotomy. Thus, this patient chose to continue conservative management and repeated dilations. So it's worthwhile to note that recurrent dysphagia in a post-esophageectomy patient doesn't necessarily imply that they have recurrent cancer. So going on, in 2011 and 2012, we had anecdotally noted that many patients were not making it to surgery. This led our cancer committee to perform a QI study where we investigated our experience over a 6-year period from 2008 to 2013. We had treated 169 patients with esophageal cancer, and 68 patients received neoadjuvant protocols. Earlier on, we were participating in the SWOG 0356 randomized trial, which included oxaliplatin 5-FU. More typically, we are currently using the CROSS trial with carbotaxol and 5-FU. We looked at patient demographics, their social support system, their weight loss that occurred, their performance status, the interventions by our nutritional teams, complications, and outcomes. So the mean age of our patients were at 62. Unique to our VA, since we cover a wide geographic expanse from including Alaska, Eastern Washington, Montana, Idaho, Northern Oregon, the majority of our patients require lodging, and actually the mean distance to travel in our VISN to treat esophageal cancer is over 400 miles. Many of you are familiar with these types of social issues. Half of our patients are either single or live alone. 30% actually came with no family support. And not surprisingly, it's difficult and challenging to administer a complex treatment course. 15% of our patients suffered treatment delays. 18% had required termination of therapy due to grade 3 or 4 toxicity. A third of the patients required hospitalizations, and most frustratingly, 40% of patients required at least one and oftentimes multiple ER visits, since we really don't have a primary care provider when they're lodging at our facility. What's the impact of our neoadjuvant treatment in our patients? All of us have seen a decline in their functional status. That bears out here. And the important thing we found out, which we didn't realize, was that only 42% of our patients that resulted in ECOG score greater than 1 were able to actually undergo esophagectomy. Weight loss, we've all seen it for those of you that manage esophageal cancer patients. Nearly 80% of patients reported significant weight loss 3 to 6 months prior to diagnosis, and over half actually experienced more than 30 pounds. And this was compounded with the neoadjuvant therapy. 95% of patients experienced more weight loss, with 40% experiencing more than an additional 10 pounds of weight loss. So this led us to look at what our nutritional intervention was for these patients. And this was enlightening and sobering at the same time. Only 78% of patients, despite the widespread occurrence of nutritional deficiencies, were actually seen by nutritionists. Less than half of patients had nutritional labs checked a single time during the course of their 5 weeks of chemotherapy radiation. A quarter of patients were not provided nutritional supplements. Only 15% actually had feeding tubes placed. We were surprised and shocked to find actually the scope of the problem. Over that 6-year period, we actually found amongst myself and the 2 other surgeons at our institution that perform esophagectomies, only half of our patients that started chemotherapy radiation for planned surgery were making it. And 62% were only able to have surgery within the ideal time period of 6 to 8 weeks. It becomes much more hazardous to actually perform an esophagectomy after 10 to 12 weeks due to the increased fibrosis post-radiation and the increased risk of bleeding in the chest. Looking at reasons for failure, listed here, and the most common reasons were disease progression, decline in functional status, and decline in nutritional status. So again, these were very sobering results to present to our cancer committee. Half of patients failed to undergo planned surgery. 40% of cases were delayed due to complications of chemotherapy radiation. There's a trend towards increasing nutritional complications, and in data not shown, there was patients that weren't able to go into surgery compared to the surgical group had a worse survival. I know we always raise alarm bells in a VA community when we say the word action plan, so I apologize. But this led us to do an immediate action plan at our cancer committee. Was we instituted a larger base study to define better patient selection criteria. We recruited clinical champions in both GI and surgical critical care to lead multi-specialty nutritional groups to follow all esophageal cancer patients. We're continue to work and improve communication between specialty services, develop clinical care pathways, and the vision, our vision has taken the really kind of novel approach of funding cancer navigator teams, which have been placed at all referral sites and tertiary sites to help manage the challenges of long-distance travel patients. This is an example of our critical care pathway at our institution currently. We divided it by specialty primarily to identify people to take ownership of the patients during certain segments of their treatment. During the early period, surgical oncology managed the primary staging, the preoperative workup, determine their surgical candidacy, assess whether they need a feeding tube, and present the case to all the specialties at tumor board. When they initiate radiation and chemotherapy, the radiation group takes primary responsibility with biweekly assessments, charting albumin, prealbumin, weight, and calorie counts, and consulting nutrition as needed. Upon the conclusion of 5 weeks, the medical oncology services then follow the patients, follow the same schedule, and then surgery obtains the restaging studies, and if the patients are able to undergo surgery, we'll manage those patients and represent it at tumor board to review pathology. I hope that we maybe have an opportunity to present the effectiveness of these clinical pathways and our new teams at a future meeting. Lastly, I'd like to talk about how do we manage the challenging R1 microscopic margin. This is an interesting And unfortunately, interesting for patients means a difficult or a dilemma. This was a locally advanced distal esophageal cancer patient, was able to undergo chemotherapy, radiation, esophagectomy, and unfortunately had multifocal skip disease throughout the esophagus and also present at the margin, at the esophageal margin. This was a case of a similar patient with a GE junction tumor. This was a patient who was unable to have a transhiatal esophagectomy due to a previous head and neck cancer and had a standard Ivory-Lewis or a thoracic anastomosis done. And unfortunately had wide mucin pools with scattered, rare, but unfortunately viable carcinoma cells at the distal gastric margin. Now, the clinical importance of the close margin has been well established for at least rectal cancer, and this has led the UK Royal College of Pathologists to define a positive circumferential margin to include within 1 millimeter of the resection margin. Contrastingly, the U.S. College of American Pathologists actually defined a positive margin as tumors strictly at the present resection margin. So there's ongoing controversy as to really which diagnosis more reliably predicts outcome. So here I compiled 10 studies addressing circumferential margin status in T3 tumors that have been resected. And altogether, there's a 14% positive resection margin in patients by U.S. criteria and higher of 43% by UK criteria. If we isolate that to just studies, patients that received chemotherapy radiation, in both groups, the overall circumferential margin rate goes down. This is a large meta-analysis that was done by a UK group. It looked at 14 studies involving 2,400 patients. Not surprisingly, a positive circumferential margin by either criteria resulted in a higher group. But most interestingly, meta-analysis demonstrated that lymph node metastases was actually a greater predictor of negative outcome compared to circumferential margin. Here I took 4 large sites, high-volume sites, Virginia Mason, MD Anderson, as well as one site from the Netherlands and the UK. And I'll ask if you can direct your attention to the yellow, sorry for that, the yellow highlighted group here. And you can see if we go by the US criteria of tumor strictly present at the margin, you'll see that in each of the studies, at both European, UK, as well as US sites, there's a significant worse survival in patients that had margin positivity defined by US criteria. Interestingly, you take those identical patients and reevaluate them according to UK criteria within 1 millimeter. Even though there's a higher incidence of circumferential margin status, the outcomes actually remained no different. So I'll summarize the talk by bringing this full circle back to the University of Michigan and paying homage to Dr. Oringer. In his study of over 1,000 patients, and this is an example where a single surgeon in a single institutional study actually has some value. Amongst 1,000 patients, this is 26 patients that actually had a positive gastric margin, and interestingly, 16 patients, or 62%, actually eventually died of distant disease, not local disease. And 9 patients were selectively given adjuvant treatment, but to no avail, with no difference in survival, or more importantly, palliation of dysphagia. So with this limited evidence that we have, I would conclude with these following at least personal recommendations. Surgery should maintain a gross margin of at least 5 centimeters from the palpable tumor. The close esophageal margin is really not the same as the close rectal margin. Neoadjuvant treatment reduces margin rates. And nodal disease really is probably the more important criteria that should guide adjuvant treatment decisions. And there's really minimal evidence to support adjuvant treatment for circumferential margins. The possibility still remains of re-resecting this lesion and coming back to perform a colon or jejunal interposition. But this is fairly morbid, and few patients could tolerate this kind of approach. So again, thank you for the invitation. I'd like to acknowledge both my friend, colleague, and research mentor who at least helped me obtain my first merit grant, Dr. Daniel Wu, who's the chief of our medical oncology section, and Alicia Kim, who is our cancer care quality coordinator, who helped put together and analyze this data. Thanks.